Hey everyone, and welcome. Today we're jumping right into a condition you are absolutely guaranteed to see in your practice: hand, foot, and mouth disease. We're not just going to memorize facts, though. We're going to treat this like a real clinical case that we have to solve together. So let's get into it.
Okay, picture this. You're in the clinic. A parent walks in with their 4-year-old who's got a fever, is refusing to eat because their mouth is just killing them, and when you take a look, you see ulcers all over. This is such a classic scenario. So what's the first thing that pops into your head? What's on your differential diagnosis list? This is exactly where our detective work begins.
Now, any good clinician knows you don't jump to conclusions. We're going to be methodical, we'll gather the clues, we'll analyze the signs, and we'll follow a logical path to figure out exactly what's going on. And here's our game plan. First, we'll look at the clinical presentation, what the patient actually looks and feels like. Then, we'll unmask the virus behind it all. We'll even take a quick peek under the microscope to see what it's doing. After that comes the really crucial part, ruling out the lookalikes. And finally, we'll put it all together and build a solid treatment plan.
Okay, first up, the history and physical. This is all about what you're seeing and hearing right there in the dental chair. What are the key things in the patient's story that should make your brain start thinking, this could be hand, foot, and mouth disease?
So this is your classic patient profile. You're almost always looking at a really young child, usually under 5 years old. Their main complaint, the reason they're seeing you, is a super sore mouth that makes it hard to eat or drink. The parent will probably tell you it all started with a low-grade fever, the kid just feeling kind of crummy, maybe some swollen glands. But here's the good news, and a really key feature: this thing takes care of itself. The whole ordeal is typically over and done with in about a week or two.
All right, so we have the clinical story. Now, let's put on our science hats for a minute. What microbe is actually responsible for this, and how does it cause these very specific symptoms? Meet our culprit, the Coxsackievirus. It's a part of the picornavirus family, and the two strains you'll see cause this most often are type A16 or Enterovirus 71. The really important thing to remember here is that this little RNA virus is highly contagious. That's why it spreads like wildfire through places like daycares and preschools.
So how does it get around? Well, it's all about direct contact: saliva, fluid from the blisters, nasal secretions, or even the fecal-oral route. Once the virus gets in, it doesn't just stay put. It hitches a ride in the bloodstream, a phase we call viremia. And this little road trip through the body explains why the symptoms show up in such specific places. The virus just has a preference, a predilection for setting up shop in the oral mucosa and the skin of the hands and feet.
Okay, time for the oral exam. What are you looking for? The lesions actually start as tiny blisters, or vesicles, but they're so fragile they pop almost immediately. So what you'll usually see are the ulcers left behind. They'll be covered by a yellowish membrane and surrounded by a red halo. They tend to pop up on the palate, tongue, and the inside of the cheeks. Now, here it is, the single most important diagnostic clue, so burn this into your brain. The lips and the gingiva are usually spared, totally clear. That one finding is your best friend when you're trying to figure this out.
Of course, it's not called mouth disease for a reason. You have to check the hands and feet. These skin lesions tend to show up around the same time as the mouth sores. They start as flat or slightly raised red spots, then they turn into vesicles, and then they ulcerate. And as the name suggests, you'll find them on the feet, toes, hands, and fingers. And here is some great news you can give the parents. These lesions heal up completely without leaving any scars.
So we've covered the big picture. Now, in the real world, you're almost never going to do a biopsy for this. But understanding what's happening on a cellular level really helps connect the dots. So let's zoom way in for a second.
The microscopic hallmark of this disease is something called an intraepithelial vesicle. All that means is that the blister forms within the epithelial layer itself. The Coxsackievirus works by getting inside the skin cells, the keratinocytes, and hijacking them to make more copies of itself. This process ends up destroying the cells, and that destruction creates the little fluid-filled pocket that we see as a blister.
So, if you did send a sample to a lab, the pathologist's report would highlight a few things. They'd probably see pink staining inclusions inside the infected cells. They'd note the destruction of the keratinocytes, and they'd see that the vesicle itself is full of protein gunk and inflammatory cells that have rushed to the scene. It's basically a microscopic confirmation of the viral attack.
Okay, we've built a really strong case for hand, foot, and mouth disease. But a great clinician is always a bit paranoid. This next part is arguably the most important for your day-to-day practice, making absolutely sure it isn't something else.
And the #1 suspect on our list of mimics the great pretender, is primary herpetic gingivostomatitis. That's the first infection with the herpes simplex virus. They both show up with a fever, malaise, and oral ulcers in a young kid. So how in the world do you tell them apart?
This slide right here is your clinical cheat sheet. Let's break it down. Remember that crucial clue I told you about? Here it is again. In hand, foot, and mouth, the gingiva is spared. It looks normal. But in primary herpes, you'll see a fiery red, swollen, painful gingivitis. That is the key differentiator. Also, check the lips. Spared in HFMD, but very common in herpes. Systemically, herpes is usually a rougher ride with a higher fever. And of course, the smoking gun for HFMD is finding those characteristic lesions on the hands and feet.
Now let's zoom out a little. Herpes is the main one, but what about chickenpox, varicella? This table helps keep things organized. Look at the primary site. HFMD is mouth, hands, and feet. Herpes is in and around the mouth. Chickenpox starts on the trunk and face, then spreads out. That gingival sign is still our best tool to separate HFMD and herpes. And the lesion pattern is also a big giveaway. HFMD has that very specific distribution, while chickenpox has that diffuse, dewdrop on a rose petal appearance all over the body.
So, you've done your due diligence, you've ruled out the mimics, and you're confident in your diagnosis of hand, foot, mouth disease. The parent is looking at you, worried, and asks, "Okay, doc, so what do we do now?"
And the answer, thankfully, is refreshingly simple. There is no antiviral cure for Coxsackievirus. Our entire approach is just symptomatic and supportive. We are focused on keeping the patient comfortable and hydrated while their own immune system does all the heavy lifting. That's a crucial message for the family. So what's in our toolkit? Well, number 1, 2, and 3 is pain control. The biggest risk here isn't the virus itself. It's that the mouth hurts so much the child stops drinking and gets dehydrated. So advise things like soft, bland foods. A simple, soothing mouth rinse with a little baking soda in warm water can help too. You also need to tell parents to watch for signs of dehydration. And in rare, severe cases, especially with that Enterovirus 71 strain, hospitalization might be needed if a child simply can't stay hydrated on their own.
And this quote really sums up the prognosis perfectly. This is your message of reassurance. The condition resolves spontaneously in 1 to 2 weeks. Recovery is uneventful. For the vast majority of kids, it just goes away on its own and the recovery is totally smooth.
So let's end on this thought. As a future dental professional, your most powerful tools for this disease aren't in a prescription pad. They're your diagnostic skills and your ability to communicate. You provide immense value by correctly identifying this benign condition, separating it from more serious ones, and giving a worried parent a clear explanation and a calm path forward. So, think about it. What's the most critical piece of information you'll share with that concerned parent? That's the art of clinical practice. Thanks for joining me.